Everyone, today we'll start with our first case. As you requested, we'll start simple with a 99 years old patient. 99, okay? He's presented with acute disorientation, okay? So his MRI, you'll see a lot of motion artifacts because he's drowsy, disoriented, not very well alert, okay? So to determine what is the cause of his sudden disorientation.
Axial tumor
Mhm.
of the brain. There is a extra axial hyperintense
T1 hyperintense.
hyperintense, bit heterogeneous,
Okay. Hyperintense what? Extraaxial what?
mass-like lesion
Okay.
on the occipital
Good.
parietal.
Parietal. ليش occipital? It's you said extraaxial. So you don't say parietal lobe. Over the parietal lobe. Maybe. What? So what do you think is this lesion?
Mostly it's a hematoma.
It's a hematoma. Which kind of hematoma?
Extradural.
Extradural hematoma. In a 99 years old patient, this suggests what's the cause of the hematoma?
Maybe trauma.
Most likely it's traumatic. Extradural is almost always traumatic. Okay? Which one is more common in the elderly? Extra, subdural, or subarachnoid? Subdural is much more common due to
Blood vessels and
due to brain atrophy. Due to the brain atrophy. Now, the question is, what is the age of this hematoma? That's the main teaching point of this case. So, in order to determine the age, we will divide the screen into two. We will put T2 here, and we will put T1 here. صح?
Yes.
And we'll try to see the signal on T1 and T2. What's on T1, the signal?
Hyper.
It's bright.
Yeah, bright.
What about T2?
It's low.
So what's the age? You know the mnemonic? It bit baby doodoo. This is an early subacute extradural hematoma. تمام? Is this the only hematoma here?
No, there's extension.
There is extension? No. There is another one.
Another one.
What is the difference between the first one and the second one?
This one ISO.
This one is intra-axial,
Yes,
intraparenchymal,
yes.
where it's anatomical location. يلا جماعة اللي هو anatomy.
High basal ganglia.
What part of the basal ganglia specifically? Thalamus. What's the age of this other hematoma?
ISO.
ISO? Dark. Is this ISO thing? Let's do a little bit manipulation and let's see even better because the motion artifact is it's dark. Okay? What's the dark?
Chronic.
It's a chronic one. So which one is the cause of his disorientation?
The new one.
The new one. This is an old one. It doesn't matter. Then 56-year-old female patient presented with sudden drowsiness and disorientation. What do we have here? And
Brain MRI
good.
T1 showing a heterogeneous area at the right side of it's been the deep green.
These are the basal ganglia.
Basal ganglia.
What part of the basal ganglia specifically?
Caudate and
Head of caudate
head of caudate and lentiform.
and lentiform nucleus. What is this abnormal signal?
Little height in T1 and it is heterogeneous in
T2, it's heterogeneous. In T1, it's more in the favor of the high.
yeah, high.
In T2, it's heterogeneously hypo or heterogeneously hyper?
Hyper.
Hyper. صح؟
Hyper.
Hyper.
Heterogeneously hyper.
تمام. So, all we need to do now is to put two beside each other. First T1 and second T2. Okay? And if you just make it a little bit more hard window to make it even more obvious. Now, what do you have?
I have an area at the right side of basal ganglia.
Intra or extraaxial?
Intraaxial.
Intraaxial, right basal ganglia.
Right basal ganglia.
Mass-like lesion.
Yes.
Appears
High in T1. Heterogeneous, predominantly high in T2.
So it's hyper.
Hyper.
Or bright.
Yes.
يعني big. So this is
late subacute
intraparenchymal or intraaxial hematoma. Got it? That's how we use this baby doodle. There is a timing for each part. The first few hours, first few days, first few weeks, first few months. Okay?
There's pressure effect.
Mass effect. Yeah, on the ipsilateral lateral ventricle, causing compression and
but no
midline shift and no hydrocephalus. Still, 49 years old, presented with free fluid in the abdomen following hysterectomy. أكثر من هيش detailed. Okay. So CT scan طبعا not resolving. So CT scan is recommended. طبعا CT abdomen pelvis. Yeah. So huh? After hysterectomy, yes.
This is training to you with a DJ catheter present in the left side.
Double J catheter is seen on the left side. In good position or in bad position on the left side?
On the left side, it's what is a minute? I think there's another DJ catheter present in the right side, but it's not in a good position. But while in the left side, it's in a good position.
So, bilateral double J catheter. The one on the left side is in satisfactory position. What about the one on the right side?
It's not in a satisfactory. I think it's low in position.
Low in position. Okay, and what else do you see here? Talk. Don't stay silent.
This is
delay phase of abdominal pelvis CT scan, axial images showing
a delay scan showing mild to moderate hydronephrosis of the right pelvic system with homogeneous, well-defined fluid density. What's fluid? Fluid density present in the right iliac fossa.
So what would we say to the referring physician?
On side of the hysterectomy.
So where's the bladder?
Here this should be the bladder.
And this is what?
This is the collection.
Collection. What
Yes.
kind of collection? Pus يعني abscess hematoma ascites ايش ما ادري ايش. Urine.
Yes.
Why urine?
Because of the extravasation of the contrast from the bladder into the posterior.
Where is the extravasation? From where? I mean, what I tell the surgeon. What do you see here? What's going on?
The double J is totally in the pelvis.
The left double J is good position.
Yes.
هذا
That
الجانب.
one I mean.
The right double J,
It's totally in the pelvis.
head. So now it's not in the ureter or kidney or whatever. Okay. Now we are going somewhere. Hassan, we have the left side, we have no problem with. Now let's see the right side. Let's start from the beginning. We have the Foley in the bladder. صح? Here's the rectum. Here's the vagina. تمام? And then we go up. The right, sorry, double J. It's the loop. And as we go up, let's follow it up. It make a loop and settles where? Here. In the recto-vaginal pouch. صح? Then, to confirm, what do we need to do? We go to the delayed. We have contrast in the urinary bladder with the Foley catheter. Tamam? And then we go up. And what's that? We have a contrast in the recto-vaginal pouch. So where is this contrast coming from?
It's coming from the penetration of the double J catheter through the urinary.
From the left kidney, going into the bladder, and from the bladder going back through the right double J into the recto-vaginal pouch. Okay? So what happened is that this double J is definitely puncturing the, not the bladder, the ureter. Okay? This one. Let's see here. See? This double J, how do they insert the double J? Retrograde. They go from the bladder, they put it up to the kidney. So the surgeon wants on the left side, put to the kidney, everything is okay. Then he come on the right side, put it went out of the ureter and coiled in the recto-vaginal pouch, this thing here. So the urine is coming like that and coming back like that, collecting in here. Let's do a lateral view where it's collected here. This is the bladder. See? It's like that, making a loop. Now, this is the question. This is the big medical legal question. What do you think happened in the surgery of this patient? What's the most likely scenario? You have a gynecologist doing the hysterectomy. You have a urologist putting the double G. Which one messed up? The most common cause of ureteric injury is hysterectomy. So what happened? The gynecologist went in, take the uterus, and take the right ureter with him. And then the urologist, the full urologist, he went, put the double J on the left, it's okay. On the right, ureter is injured. It went out.
So the distal part of the catheter is in the urinary bladder.
Yeah.
And the proximal part is in the lower part of the ureter. And the vagina.
Yeah, before the injury. Yeah. Let's go to the without contrast and try to make a 3D. I don't know. This is without contrast. See, this in the urinary bladder, and then goes up the ureter, and then out of the ureter, and do this loop in the recto-vaginal pouch. You see, like that. In the urinary bladder, goes up the ureter and out of the ureter.
And most of it's outside.
The vast majority. This is a big urinoma here and here, everywhere. كل ما بالموضوع انه بالديليت image. طبعا we delay for 5-10 minutes. Contrast in the rectovaginal pouch. Okay, wait for 4-5 hours. It will be even here. ديلي ايش قاعد نطول 10 دقائق 15 دقيقة ايش قاعدين يطولين. It's all one big urinoma. Got it? شوف هسه هذا. Okay, let's see another trick. This is double J density. This is contrast density. Okay, so till here it's only contrast, only contrast, only contrast. See double J shown dense? This is only contrast. Till here we have nothing in the ureter. And then cut. And the double J here with contrast. Okay, see the double J coming like that. And see? Getting out of the ureter. وهنا صار واحدة.
هذا هم يورينوما دكتور؟ هذا كبير؟
طبعا هذا yes. هاي contrast B بالديليت فيز.